The broadcast is now starting. All attendees are in listen-only mode.
Welcome back, everyone. Sorry for the short technical delay. It appears Deanna's home internet actually went out on us during the call. Thankfully, everything's working now. We'll go ahead and get started, try to stay on time so we don't take up too much of your day here. So with that, I would like to welcome Deanna.
Good morning again, everyone. My sincere apologies. I am technologically impaired sometimes. I am having internet problems sometimes with Spectrum here, and I think that just shut down for a few minutes. But it seems to be working now. So again, my apologies, and we'll move forward. So just to remind everyone that the purpose of our calls is to provide streamlined access to pertinent materials and resources to our members. We are trying hard to vet each of our materials and resources as they go out, because we know that people are inundated with the number of executive orders, CMS guidelines, etc. But we also want to keep everyone up to date as much as possible. We are monitoring the spread of illness ourselves as it moves across Michigan, and we want to keep everyone updated as to that. We put the daily updates on our website in one place, both national and for Michigan, so that you can look there. And most importantly, what we want to do during these webinars is to have members share how things are working, what the challenges are, what issues may be coming up as we move forward during this experience. And also, last but certainly not least, is to get ideas from you about what your needs are so that we can inform our advocacy here in Lansing. And there's an awful lot of communication going on between us and the legislature, the department, and the governor's office. So today what I'm going to do is go through this agenda, look at our current situation, talk about our advocacy to date, talk about our most recent resources and changes that have come out, and then go to a time where I hope that members will be able to talk a little bit about what's working for them, what isn't working for them. And for that period, I'm kind of focusing on the CMS guideline that came out last week about visitation and other issues, because most of our questions that we've gotten in the last week or so surround that. We'll move forward from that piece. As of this morning, actually as of yesterday, the data hasn't been updated. We have about 4,000 cases across the United States, and you'll see that it is rapidly increasing quite a bit. I'm sorry, the death column is obviously an error there, but from 423 cases on 3/9 to 3/17, where we have 4226, is a huge increase. And of course, the experts are telling us that there's no way to anticipate how much spread is really occurring because the testing really hasn't been thoroughly done yet. So we anticipate it's going to be several weeks before we know how bad it's going to be and how we're going to get our arms around it. Michigan currently has 61 to 100 cases that have been confirmed. You can see kind of in the middle area states where it's a little bit lighter. And we find that in Michigan, the high numbers tend to be in the urban areas. Testing has been hard. I think that part of the dilemma, as we all know, is the delay in getting testing kits. And even though we hear messages that everyone should be able to be tested, at this point, they really are testing only those persons who may have symptoms or have had close contact with someone who may have had the illness. This is the number of cases that have been determined positive through 3/15. but the downward slope is really not well representative of what's happening, because illnesses that may have occurred during that time are obviously not reported yet. In Michigan, you'll notice that part of this is empty because Michigan has changed the way it's reporting, and it's really just reporting positive numbers now. And we have 65 as of yesterday. This is the spread of where the cases are in Michigan. You'll notice that Oakland County is the largest county with cases to date. And the counties with the urban areas, Washtenaw, Wayne, Oakland, Macomb, and obviously Detroit is separated out. Those are the counties where the largest number of cases seem to be at this point. So we're going to continue to track that by county. I think that it might be helpful for you to look at that every week as cases occur in your county. I think it's important to know how the spread is moving. One of the things that was really, really surprising to me was that the largest number of cases are occurring in the 60 to 69 age group. Now that might be really an error, not an error, but not true, because it's possible that there are a lot of cases in the younger age groups that, because they're so mild and because testing is so scarce, that they simply haven't been uncovered. And the 60-69 age group is a little bit more mobile than older persons, but they also have a lot of risk factors. So we might be seeing that right now in that age group because of those factors. Also note that only 25 of the 65 cases are known to be hospitalized. So a lot of people are being cared for outside of the system at this point. This is a slide that has been shared in a lot of different venues. It's meant to identify the need to really work to contain this. The concern, of course, is overwhelming the healthcare system. I think everyone has heard those messages. And the difference is that if we don't contain it, we will not be able to care for those people who will really need it, especially those people who will need hospitalization and potentially ventilators. So we want to continue this message and to ensure that communities are aware that people need to take this seriously and attempt to follow all of the precautions for their area and age group that they can. So our advocacy to date, we've been working on an awful lot of issues, excuse me, with all of the departments, the governor's office and the legislature. There are a lot of things that are in front of us. One of the things that we continue to be concerned about is the implementation of a new SNF reimbursement system. There are SNF rate cuts baked into that system. It's still scheduled in the governor's budget to start October 1. We are in discussion with the department, the legislature, and the governor about this. We were strongly opposed to this before the outbreak, and the outbreak just makes it obviously more clear that rate cuts right now to any long-term supports and services provider would be very, very devastating. There is a bill in Congress right now that has not been signed yet, but may increase our federal Medicaid funding proportion. In other words, the amount that the feds give to each state, it increases it a bit during the outbreak. We want to make sure that any additional federal Medicaid funding goes straight to our providers in terms of rates and not somewhere else. The state has an awful lot of ability to move that money around as needed. So if we get a little bit more federal funds, we want to make sure it supports our rates so that we can support the consumers. Medicaid emergency funds, you know, the department does have a process for providers to gain Medicaid emergency funds when necessary. We want to streamline that availability. We're talking to the department about that sort of thing, actually as we speak this morning. And we also want HUD to defer any mortgage payments for our excuse me, housing members. We are asking for a direct wage pass-through to support the ability to employ more nurse assistants. We have a severe shortage of nurse assistants already in many areas, and we want to be able to provide a little bit more funding so that we can pay them wages that would be a little bit more attractive. There is federal legislation pending to support expanded unemployment benefits. That's that same bill that I was talking about earlier with the FMAP. One of the big things that we'll talk about later is to leverage the state's buying power to get personal protective equipment and other supplies that our members need. We're in discussion about that, and we need to talk about this a little bit further because right now I'm not aware of any good answers about supply shortages, and I want to have a discussion with you all about how successful you are at this point. And to be honest, I haven't heard a whole lot of success. So the department's currently working on a provider letter that will allow for flexibility in how you use your beds, maybe accessing escrowed beds, providing private rooms for Medicaid residents without approval. That might have already come through. We're working on that. The governor did provide in an executive order last night to Laura their ability to do this kind of work without going through the normal channels. So we anticipate that we will get some information from Laura in the near future that talks about how you can use your beds if you need to make some changes based on need. The governor's executive order from last night allows non-certified staff and volunteers, well, we think it does. Our goal was to allow non-certified staff and volunteers to provide direct care as necessary, including a temporary waiver of staffing rules and allowing nursing students to perform CNA tasks. This essentially has been done. We will talk a little bit about the executive order in a few minutes. Right now, staffing level requirements still apply, but there is some language in last night's order that allows us to use people who are not currently certified in those roles, and we'll talk about that. Assistance with child care, we have been in discussion about that. That has not really moved very well forward. There has been a lot of discussion about mobilizing the National Guard if we have to, but I don't think the governor is there yet. Waiving patient transfer requirements if needed, that's a CMS discussion, and we've been talking through leading age with them. Limitation of the ombudsman to virtual visits, that has been done in a letter from the ombudsman already. So while they will follow up on some complaints, they are mostly going to be using virtual visits, so they won't be coming into your facilities. So that's a lot of stuff. We continue to work and talk to the regulatory entities in many, many areas. The federal government has put out blanket waivers under Medicare. So this really only applies to Medicare providers. And these blanket waivers, while they might be a little helpful, really don't do what we wanted the waivers to do. So we want a little bit more from the feds than this. Currently, you don't have to apply for these waivers. The first one is for a 3-day prior hospital requirement waiver. The thing that concerns me about this is the language. And I've had some questions about it, and we have questions into Leading Age. Leading Age has a conference call this afternoon with CMS, because the language here says for those people who are evacuated, transferred, or otherwise dislocated as a result of the effect of the disaster. So that's unclear to me about whether or not you're talking about any admissions during the disaster, and that doesn't really say that to me. It may only be for people who you may have to transfer very quickly because of the outbreak. Additionally, if someone has exhausted their SNF benefits, they will authorize renewed SNF coverage. You have to meet the criteria without first having to start a new benefit period. And this is a blanket waiver for all impacted facilities. I'm assuming impacted facilities mean pretty much all facilities because we are under a national emergency. But those are things that we are trying to get clarified from CMS.
I just received a question regarding that, Deanna. Sorry to interrupt.
Okay.
But will that send people from our facilities? Will that send people to our facilities from the streets or under quarantine?
That's what I don't know yet. I really don't know if and I'm assuming we're still talking about the waiver for the 3-day prior hospitalization. I don't know if that means that you can accept people without any hospitalization at all. I would assume that. If people, if we get to an emergency situation where the hospital is full, you have a person with long-term care needs or some mild care needs, it's possible that CMS will decide to use nursing homes as a point of care. It depends on how that moves forward. At this point, though, I would anticipate that your admissions do not need a 3-day prior hospital stay. The question that I have is it just for those people who are immediately impacted by the disaster or emergency? So we need some clarity around this whole issue, and we will be talking to CMS and Leading Age to help get some parameters around that. Because it sounded so clear to me in the beginning, but as we've read it and reread it, I find a lot of unclear information here. The waiver also provides relief to SNFs on the timeframe requirements for the MDS assessments and transmission time. So that's helpful. So you don't have to rely on the timeliness in order to get your documents in and your bills paid for.
There is some.
So those would be.
The follow-up question is could this be forced admission?
At this point, they cannot do that. That is one subject that I want to talk about later. How you really feel about taking persons who have COVID-19, if you have a current community that is infection-free? That is one of the things that I want us all to discuss together a little bit later in the webinar. I think that at this point, they can't make you take an admission. Those rules have not changed. However, if things get very, very difficult, CMS and the state can change those rules. So we'll have to see how that plays out for right now. Any other questions about these waivers?
I don't have any regarding the waivers.
Okay. So those are the 2 blanket federal waivers, and then a lot of states have requested state level waivers. There are 2, there's really only one that's been approved to date. And CMS has approved Florida's emergency Medicaid waiver request. We are working with the department to consider some additional things that we need from the federal government in order to ensure that we can deal with the consumer need in this crisis. So Florida has submitted its Medicaid waiver, and that waiver includes fast-track provider enrollment. In other words, you can become a provider if you need to in this emergency very quickly. They have Medicaid pre-authorization requirements for getting into nursing homes, so they're waiving some of those. They're waiving their PASR screening for the next 30 days. They're allowing care in alternate settings so that it's possible if our skilled nursing facilities become very busy and overrun, that some patients can move to alternative settings. And they're temporarily delaying Medicaid hearings and decisions. So these are some of the things that need federal approval before Medicaid can do. This morning, I know that there are discussions between the associations and the department about what Michigan might need regarding this. Pennsylvania, I wrote that this was a state waiver, but Pennsylvania did this without a state waiver. They waived their SNF staff minimum requirements, and they can do that because that's a state law, not a federal law. They waived their personal care home and AL staffing requirements because apparently they have state rules about that. For Pennsylvania, providers must notify when the staffing does drop below the minimum standards, however. And I wrote this before the governor's executive order yesterday, so it was important to note that the state has the ability to change its rules for persons who normally would be required to be a CNA, a certified nurse assistant, because the actual training rules come from the state. And so Pennsylvania has decided to provide that flexibility for individuals to perform certain tasks, and they identified with abbreviated focus training. So there is a training element that's required, but they're not required to go through all of the certification process. And I think this is important as we move forward because this element is also included in the executive order yesterday, and we're going to talk about that a little bit more in a few minutes. Immediate licensure for nurses who are licensed in other states so that nurses can cross borders more easily. They still do not have, there was a request from the Pennsylvania leading age affiliate to have provider staff be able to bring childcare on site. Pennsylvania did not do that. And I think that there's a reason for that. I think that considering that children can be major carriers of this disease, and not even perhaps show any symptoms of it, would be difficult to bring them into an area where there is a lot of persons who are frail and vulnerable. So unless there's some way to keep a major barrier, I can understand why Pennsylvania chose not to do that, although the affiliate wanted that kind of a waiver as well. Okay, so I know I'm talking fast, and I know that there's a lot of things, so feel free to ask questions as we move forward. What I want to do now before we talk together a little bit is to go through our most recent resource updates and talk about what's happened in the last 24 to 48 hours. So right now there is a $125 million funding bill in the Senate that will help move monies to providers and other areas in order to support the coronavirus outbreak. We expected some House action last night. I don't think that that happened yet. So there was originally a $50 million bill. I'm sorry, there's $50 million for healthcare, $50 million for other needs, and $35 for additional spending to be made available. So we're looking for more funding than the bill that was created last week that I think provided a total of $25 million. So there's money coming down the road. How they're going to spend it is not 100% clear to me yet, but we will see how it's going to go. I don't know what healthcare needs means. So we'll be monitoring this very closely and see how that works out. The most important thing from yesterday was the governor's executive order, and it was effective immediately through 4/14. We have been looking at this language. A couple members have emailed me about what the language actually means. The first issue is that the departments can work together to ensure more persons receive care through emergency certificates of need. So they're waiving or deferring certain requirements to bring additional care facilities online. They can put together mobile facilities, temporary facilities. We anticipate that that might be happening on the healthcare, on the hospital side. They can also look at how nursing homes use their beds and might avoid some certificate of need issues as we move forward. The governor has given each of these departments the flexibility to do this without going through huge planning and regulatory changes to do that. I think one of the most important pieces is that Laura may issue temporary registrations for persons to be certified without the examination requirements. We have some questions about what that really means. Does that mean that anybody coming in off the street can be a nurse aide? Are there no training requirements at all? We anticipate that it's not going to be as simple as it appears here. We have been conversant with the department already this morning, and they, of course, are not prepared to talk about it yet. We will continue our discussions with them to see what it means. And what the process would be to get such a temporary registration for people to be able to help out. Laura, nurse license renewal granted, whether the requirements are met, and those would be CEU requirements pretty much, so you can get your license renewed regardless during this period. They're going to recognize hours worked in a COVID-19 response as hours for CEUs for licensed staff as well. And they're also allowing non-nursing assistants such as activity coordinators, social workers, and volunteers to help feed or transport as consistent with their care plan. Those are the pieces of the executive order that are really most pertinent to our members. And I think that this is a good start. I don't know that this is the end to the things that we need in order to better provide care, but this is a good start to it. Yesterday, PACE guidance came out because most patients are living within their home. They wanted to make sure that PACE providers were fully aware that they have to screen and monitor just like all of our other providers, and also screen anyone who comes into their PACE centers. They have to, because they're a managed care-like entity, they have to provide the diagnostic testing to identify COVID-19 as indicated, even those patients who are in their home. So there's nothing really surprising with this guidance. It came out yesterday, but it does kind of put some regulatory parameters on what the expectations for PACE are. The department put out an L letter. An L letter is simply a provider letter yesterday. I don't think it really has a whole lot of new information in it. It talks about decisions based on testing. They talk about that decisions should be made still on the clinical course and information about whether or not there's been contact with persons who have had the disease. To also remind people that people with symptoms should also be tested for influenza, because it's possible that the influenza virus can also be causing a lot of illness, because we're still in that period of high influenza cases, so that there are challenges to persons who are vulnerable who have influenza, and we need not forget that that's also an issue. If any criteria are met, the patient, and I would assume staff, should be immediately be placed in respiratory isolation, contact their local health department or the Department of Health and Human Services. So if you have symptoms and if you have been in close contact, those cases should be reported and they should be isolated. That's what the L letter yesterday says. And I am stuck again. So, Dalton.
Yes.
I'm stuck again.
Okay. So while we hopefully wait for Deanna to get unstuck, I do have a couple questions that maybe we can ask in the meantime.
Okay.
Hopefully, the internet graces us with its presence in between then. The first question, can we continue to have new hires come into the building for background check, paperwork, interviews, orientation, etc.?
I would think so, as long as you're screening. I think that would be the critical piece. I would think that there would be no problem with that. I would ask other members and maybe Laura Funch to weigh in here, but I would think that that would be something that's appropriate. Okay, my screen is working again. Laura Funch, if you're on the line, do you have any thoughts about that?
Let me see if I can find her amongst everyone here. Ah, here she is. Laura Funch, I just unmuted you if you'd like to speak.
Yeah, I'm on the line. Thanks, Deanna. Yeah, I agree with you, Deanna, that would be a very appropriate thing to do. Appropriate screening and whatnot, the education, make sure that the infection control practices are well educated. But yeah, I mean, the bureaus or the governors allowing for other folks to come and take care of our residents, so limiting new staff would not, if I'm understanding the question right, would not be something you wouldn't want to do.
Right. Okay, any other questions before we move on?
I have a couple other questions that aren't specific. If we'd like to take them now, or we can just go ahead and move on, and I can address them later.
Let's if they're not specific to this piece, let's wait. We're almost to the part where we are going to have a general discussion. And my computer keeps coming in and out, so I do apologize. Bear with me, I am back on. Providers should be working with local and state public health authorities on a case-by-case basis if they have questions about whether or not a patient, and I would include staff here, meets any of the criteria. I have heard from members that the local public health authorities have not been very helpful. And if you have specific information about that, we would like to hear that so that we can advocate in Lansing about a little bit more friendly and helpful local public health authority. I'm sure that they're stressed just like everyone else, but you know, my feeling is that our members are at the front line with the most vulnerable population, and they should be able to respond to our questions in a meaningful way. Persons awaiting test results who have been in contact with someone may be directed by public health authorities, and that could include the state or your local public health department, to isolate at home or in a healthcare facility if they need care. So I would anticipate that this might be more prevalent as things spread. So it's obviously critical that everyone be in contact with their local public health staff and develop a relationship with them, because there's going to be a lot of communication moving forward. The Bureau itself can now test specimens, and we're hoping for an improvement in turnaround time. However, I haven't heard that we've gotten a whole lot more tests yet to date. Last but not least, healthcare personnel. There's a portion of this letter that covers healthcare personnel. Any kind of healthcare person is considered at risk. There are CDC interim guidelines out there for COVID-D, COVID-19. So please, if you haven't reviewed them, this is the title of the document that you can Google and read them. It's important that you consider this, especially for anyone who may potentially be exposed to the virus. Okay, I'm not going to go through all of this slide. We will be sending out these slides shortly. These are the instruction on how to bill any diagnostic testing or any kind of treatment or care under COVID-19 diagnoses. That is part of the letter as well. So this is a copy of the executive orders. The most recent that I'm aware of so far, she puts them out rather rapidly, is the one from last night that provides flexibility to ensure the availability of health care. These are also all on our website, and you can get them as well there, access them. Okay, member challenges and discussion. So what I have done for this, I think that there might be some more questions about the waivers, some more questions about the recent executive order, but for the last week, most of the questions that we get or concerns have come from the QSO 2014 nursing home directive from CMS. One of the things, and I'm just going to go through the things that we keep hearing about, and then we're going to open up everything to questions and discussion. The compassionate care piece. CMS directed all facilities to restrict visitation of all visitors and non-essential health care personnel, except for certain compassionate care situations. There have been some discussion about, does that mean people who are actively dying? And that is kind of the interpretation that I had placed on it, and some other people have placed on it as well. Because there are a lot of patients in our facilities that are hospice patients that are actually not near death. So just being in the hospice program does not necessarily mean that it's a good idea for all those people to be receiving visitors in and out of your buildings. We are asking for some clarification about this, but that is the way that we have interpreted that. I know that that has been a challenge for some of our members. Canceling communal dining. This is an issue that has come up as a real burden. We're going to talk about that a little bit more and let you talk about what you think your needs are regarding that. And screening all staff at the beginning of the shift, being able to actually screen all your people coming in, identifying what to do in case they have any symptoms, etc. That's something that has had a lot of questions, and we'll talk about that in a bit too. Residential facilities should contact the health department if someone's suspected of having COVID-19. People can, facilities members, whether you're an AL or a SNF, you're not required to transfer your person as long as the resident doesn't need a higher level of care than you can provide, as long as you can adhere to the infection control practices related to the CDC transmission-based precautions. So I think that that's a big issue, and I guess I'd like to hear a little bit more about how well you feel that you're prepared to do that. You can accept a confirmed case as long as, again, you can follow those guidelines. There is also a CDC guidance for discontinuing precautions. I just wanted to point that out. I think that obviously we're not quite there yet. And last but certainly not least, the guidance says that equipment shortages will not be cited as long as it's beyond your control. However, that doesn't mean that you can operate well without those shortages. And we're going to talk a little bit about how that might move forward. Interpretation of the executive order. I had a couple questions this morning about the fact that It was unclear in the writing whether or not anyone off the street can become certified, and we talked about this before. Any processes for temporary certification, that is still all up in the air. And again, Laura Funch is talking to Laura, the department, to ensure that we get some information as soon as they've made some decisions about that. So, canceling communal dining. I want to give you a moment. We have communicated this hardship, and Leading Age has identified, our national affiliate has identified that this has been a problem for a lot of members across the country. They have a conference call with CMS, and this is going to come up. Do you have any questions or comments or ideas about the challenges here, or how you've made this happen, or can we just assume that it is a burden for everyone and we should continue to talk to CMS about how unreasonable this is? So we're going to open things up. Please do send Dalton a note that you would like to speak, and we'll give everyone a couple seconds to do that if you're ready to talk about this. And Dalton, then we'll open your mic.
Okay, so for this part, you can either type in a question. I know some of you have questions waiting to be asked. We'll address those later. Right now, we'll discuss community dining. Please feel free to type in the chat. I see we have one hand, a couple hands up, and I'm getting some questions in. Okay, so the first hand up that I see is Missy. Missy, I'm unmuting your line. You're unmuted now if you'd like to discuss. Hello, Missy? I see you as unmuted now. Okay.
Is there another question, Dalton?
I have, okay, I got a lot of questions in the last minute or so, and please continue to send them. Could we mobilize training of CNAs and train some families who want to provide care first?
I'm sorry, can you say that again?
Could we mobilize training of CNAs and train some families who want to provide care first?
I believe that you can probably do that under the new order, but we don't have the parameters for that. I do know that you can take your ancillary staff, and there's no question about moving them into feeding and assisting and transferring roles, as long as it makes sense for that person. Whether or not you can mobilize families, which families aren't visiting right now, so I don't know that you can take anybody from the outside who isn't meant to work in the facility right now. But I would assume that if a family member was screened, and that could be an avenue for getting some help. But I would ask Laura Funch to put that in her conversation with Laura as we move forward, because basically I think that the EO, as I read it, is really about people who are employed. I don't know that volunteers would be covered to do that sort of care or not. So I think that's a really good question, and I would ask Laura follow up with the department for that. Obviously, we don't have a good answer to that at this point. I hope I understood the question right. Next question.
We have spaced residents one at a table. We also use bedside tables 6 feet apart for residents that need to be assisted. is this acceptable?
I was talking with some staff about that yesterday. It's my thinking that at some point, people are going to have to make things work for themselves. Technically, it does not meet the requirement that CMS has put together. I have thought that people are probably not able, considering their staffing needs, to meet the communal dining piece. I think that we're going to ask for a different and better requirement from CMS. Obviously, you know, I think that technically you're outside the boundaries, but I also believe that you need to take care of your patients. So that's a decision for each individual facility. We will continue to keep our messages clear that we understand why the CMS did this. However, keeping everyone in their individual rooms is just not going to work in the long run. And as long as we have some exposure protections, we should be able to make those decisions.
Okay, we have another similar question. For residents that need more supervision during meals, is it okay to have them sit one per table in the dining room as long as they are 6 feet apart?
Well, that's kind of the same piece. Again, it's not in alignment with the CMS directive. However, again, I think that facilities are going to have to make decisions about what works for them, and we will continue to press CMS on the issue overall.
Okay, I have a bunch of other questions.
Why don't we go ahead and go to your other questions so that they don't wait until if
Okay.
They come up in my future slides would be okay.
Okay, I have another one regarding dining. In our facility, we are staging meals so that residents are served in different waves to accommodate staff being able to assist residents. So maybe that's actually a best practice.
Yes. I have heard that several facilities have kind of moved the timeline so that they're not hit with overall resource issues during meal times. And I think that is a good idea, if that works, considering all of your other scheduling and activities. So yeah, I have heard that has worked in some of the facilities. Good.
I have a response to some of the discussion. So a risk versus benefit care plan for spacing variables.
I'm sorry, Dalton, you're breaking up a little bit for me. Can you repeat that?
Oh, I'm sorry. A response is, so a risk versus benefit care plan for spacing variables.
I think the question, and I may have to confirm it again with Dalton, is do you have to care plan for spacing variables? If that's the question, I would not. I mean, if a person has been exposed or you're suspecting them of illness, I would think that you need to care plan that. And I will ask Laura to also come in here, because I'm not sure that she's going to agree, but I would think that your blanket spacing and social distancing policies should take care of the general population. But if you have someone who has illness, suspected for COVID, suspected for influenza, I would think that would need to be in the care plan. So if you can allow Laura to interject something here, I would appreciate it, Dalton.
I unmuted Laura Funch's line so she can speak.
Yes, thank you. Yeah. Yes, thank you, Deanna. I agree with you. It's throughout all the communications from CMS, they keep stressing person-centered care. So if you are able to accommodate that resident and there's benefits for that socialization, getting that resident out of their room, absolutely. I mean, as long as you're taking appropriate measures to alleviate the risk of any potential exposure, infection control, but that person-centered approach is very appropriate.
Okay, good, great.
Okay.
Okay.
For the rest of the next question, I'm going to leave your line open, Laura, just in case you'd like to respond to any of these as well, because we do have quite a few. So the next question, staff with a new cough, no fever, no known exposure, can they work with a mask?
Laura, I'll let you respond to that one.
You know, I'm going to say that that is an individual facility decision. I am going to say that will go back to a discussion with your infection control nurse, a discussion with your medical director in terms of your current screening processes for your employees. I don't think one size is going to fit all in those scenarios. I think you have to mitigate any risks, but you also have to think about what else you're not doing if you don't allow that employee in. I don't think there's a one size fit all. Consulting with your medical director, infection control practitioner, in my opinion, would be the appropriate thing, and you may have to do it on a case-by-case scenario.
Right, this is Deanna. I would agree. I think that there's nothing that prohibits you looking at persons who have mild symptoms of a cold, don't have any of the other risk factors, and as long as you are protecting the residents from any sort of infection, I think that you have to look at this as on a case-by-case basis as well.
All right.
Next question, Dalton.
Yep. If a facility is Medicare certified only, with the waivers, are they able to accept Medicaid residents?
We have not heard specifics about that, but I do believe that that was the intention of the executive order. So as things play out, I would expect that Medicare-only facilities will be able to take Medicaid patients if needed.
Excellent. Next question. If utilizing telehealth with our physicians, is there a requirement for a face-to-face?
I'm sorry, Dalton, for some reason you're breaking up a little bit for me. Can you repeat that again?
If utilizing telehealth with our physicians, is there a requirement for a face-to-face?
I'm assuming that you are looking at whether or not the physician will meet his requirements for a physician visit if he only uses telehealth. I don't have the specifics as to that answer. I do know that the administration and the president put out yesterday new Medicare guidelines for telehealth. We will look into that today and get an answer back out to the group. I believe that that is an acceptable thing at this point, but I would have to go back to the details of that directive to be sure.
Okay, next question. We require staff who received deferment for influenza vaccination to wear a mask when at work at all times. Would you recommend discontinuing this policy to preserve PPE?
Laura, I'm going to hand that one off to you.
You know, my first gut reaction is no. My gut reaction is no. I mean, that individual's, I don't know. I would have, my gut reaction is no,
right.
But I will see if I can research that somewhere.
Okay, good thought. I do know that there is a huge, go ahead, Laura, I'm sorry.
You know, so again, that risk factor, I mean, there's so many variables for that decision. Back to your infection control nurse and back to your medical director, the risk factor of that particular individual, a case by case. I'll see if I can get some information from APAC on that.
Okay, good. Next question, Dalton.
Okay, next question. Could Leading Age set up virtual CNA training and send us train the trainers out to clinical test?
Dalton, my apologies again, you're breaking up. Can you repeat?
Could Leading Age set up virtual CNA training and send us train the trainers out to clinical test?
That's certainly an idea. Let me float that by the powers that be, see if we can work through something. I really am not sure at this point. It would be interesting. I would assume that one of the things that the governor's executive order bypasses is perhaps people who don't have training on site for their CNAs. That's another issue that kind of might be assisted by this new executive order. Let's take that back and we will consider what that might mean.
Okay, next question. The slide said quarantine if confirmed positive or traveled to one of the affected areas. My understanding, the travel part was removed, as it is assumed everyone is likely exposed at this point. The whole country is affected. For example, a nurse returned from Hawaii. We were going to quarantine 14 days, but now guidance says if they are screened and not symptomatic, then they can work.
I think I might have had some old language in there, so I'm not 100% sure. I do believe that you are correct that that the travel pieces may not be as important as before, but I can confirm that and we'll look into it.
Okay, next question. Thoughts on PPE for our staff? Guidance is somewhat conflicting. CDC says consider if COVID-19 is in your community, and absolutely if it is in your building. It is in our counties. If we give PPE to staff daily, just as a precaution, we will be through our masks in no time and not have masks for when we need them for positive COVID. Thoughts?
Agreed.
I know it's a challenge.
I mean, in my opinion,
go ahead, Laura.
I mean, absolutely. I mean, I think a conservative measure, if there is no active residents in your building, nobody under suspicion, then being reasonable and using those scarce resources would be a wise thing to do. I mean, that includes your staff and everybody. That might be a very wise thing to do.
Okay, next question. Do new admits need to be quarantined for 14 days?
Again, repeat for me, Dalton.
Do new admits need to be quarantined for 14 days?
Laura, I'm going to turn this over to you after I say that that's not my understanding. If they don't meet any of the screening criteria, I'm not sure that that's being required. What are your thoughts, Laura?
No, I agree with you, Deanna. I mean, as long as folks are screening their new admits, which I believe everyone probably already is doing, and no, not necessarily, no.
All right. Next question. Could there possibly be a way to do a one-day review course / testing for those who have previously had their CNA license but have let it lapse? Basically a fast track.
Laura, I'm going to let you respond.
The Bureau, yeah, I have asked the Bureau, particularly Jim Wiggins' group, on how to interpret the governor's order last night. He said he will get back to me. I've sent out a bunch of questions to him in terms of process, all that type of stuff, first thing this morning. As soon as I get a reply, I will make sure everyone is aware, is informed. That's one of the questions.
Okay. Next, this seems to be a comment. I teach for WCC, and we have a group of students who are done with class and only needed clinical days. We asked the state if they could simulate clinical in the college simulation lab to complete their class. The state, Miss James, said no.
Well, my first response would be,
How soon?
when was that response given? Because I think
Yeah.
the executive order may eliminate that. If that response was before last night, I would say that that's probably moot at this point. But I would wait for some more details from Laura before I move forward. And Laura, I hear you're agreeing, right?
Agreed, yes.
Okay, next question. Staff who returned from a cruise without known COVID-19 present, should they be off for 14 days?
I think that's a really good question. I think cruises are like very, very difficult places right now. I don't know if there's any guidelines about that, but I would certainly be careful. And I'm going to turn this over to Laura for her response.
I agree with you, Deanna. The cruises was one of those, if I'm not mistaken, one of those criteria, if you will, for screening individuals.
Right. I think I would err on the side of caution here if it's not clear in the guideline.
Okay, so this goes back to the question regarding admissions. And the quarantine comes from a facility attached to a hospital and has had a confirmed case of COVID-19. We did have an admission that came from the hospital that was not doing the screen.
The admission came from the hospital, but what?
So they had an admission.
Go ahead, Laura.
I'll reread the question for you.
Okay.
A question regarding admits. And the quarantine comes from a facility attached to a hospital and has had a confirmed case of COVID-19. We did have an admit that came from a hospital that was not doing the screen.
They were not doing the screen.
Yeah, I think that was more of a comment. All right, the next question. So then we cannot have. Oh, I'm sorry. Go ahead, Deanna.
Well, I guess, Laura, I want to get your take on that. I mean, what are your thoughts about that?
My thought was, wow. I'm kind of just boggled that a hospital isn't doing the screenings.
Right, right.
So,
I
Tracy,
would at the very least.
Wow.
Well, go ahead.
No, I just, my mind is racing. So that resident or that person that came from the hospital, I mean, how would you know for sure that if they weren't screening, that resident was in there, who was the caregivers, all that type of stuff. That one is hard.
Right, right. And I think it speaks to the fact that the members need to have some open dialogue with their hospitals about transfers back and forth and what both members' expectations are. And Laura, I'm sorry if I cut you off, if there's more.
No, you didn't.
So the question is, do new admits coming from a hospital that has a positive COVID-19 that passed the screen, do they need a 14-day quarantine?
I think that's a hard one, Laura.
I think that these are excellent questions, and I feel a little bit reluctant without having a couple of minutes, maybe by the end of the day or not, to really really think through these questions and to reply responsibly and accurately. I'm cautious. I'll be honest.
Okay, so what we'll do is we will collect these questions and try and put kind of some responses to them and put them out as a separate piece. We do know that the guidelines are not always clear. There are always going to be some exceptions to a guideline, and we're going to have to work through some of them, and we can do that together. And facilities are going to have to look at what is best on a case-by-case basis as well. So we will try to put these questions together and send something out so that you all have a little bit better, if not guidance, perhaps an idea of what other members are doing.
So to put a bow on it, the admission came into the hospital prior to hospitals having to do the screen, but they did place them in a quarantine.
Oh, okay. Okay.
All right. Next question.
They put them in quarantine for the 14 days. Dalton, let me just clarify. So the hospital did put that resident in quarantine for 14 days before the resident was transferred to the nursing home. Is that correct?
I am not sure if it was the hospital or them. No, the SNF placed them in quarantine for 14 days.
Okay, I just wanted to clarify.
Okay, next question. So this is a question regarding masks. So then we cannot hand out masks to everyone just because COVID is in our community? Question mark.
Laura?
Wow. So definitely for sure, the folks that if COVID is in your community and that resident or residents are in isolation, then the protective equipment stuff would definitely be applicable for anyone who's caring for that resident. Does that mean the whole staff in your facility? No, it means the personal protective equipment for those folks interacting with that resident or those residents.
That would be my take as well. I would think that, that would be a little bit of a burden actually on both the facility and the residents. I understand everyone's concern, but I think that I would certainly focus on excellent isolation techniques and protective equipment for anybody who comes anywhere near the resident. But beyond that, I think masking the whole facility, it would be difficult.
They mean the community as in the outside area, not their building.
Oh. Laura, do you have a response to this?
I do not. I guess I'm not understanding the gist of the question. I'm sorry. I do not. So the question is putting a mask on.
I'm going to unmute. It's Missy's question. I'm going to go ahead and unmute Missy so she can speak here.
Good.
All right, Missy, I have you unmuted. I see you muted now. Why does it say? Okay, I unmuted you. Instead, I have another. Oh, sorry. There you go, Missy. I had the wrong person on. No. I also have it written out in another way. Said another way, when you say community, are you saying the campus or the greater community? That's another question. Greater community.
I would ask that person to write that question out with a little bit more detail and send it to our safe and calm email address, and we will get it out to everyone, because I don't think Laura nor I are understanding the question per se. So I would ask that we move to the next question. Dawn, please.
Okay. I will go ahead and do that. I think I can piece it together here and send you something. The next question is, are we at the point of triaging for rationing equipment?
Laura, I'll let you start that.
I'm sorry, somebody was emailing me a question. I apologize. What's the question?
Are we at the point of triaging supply to start rationing equipment?
I do not know that answer. I don't know what your supplies are.
My response would be, you need, in my view, depending on your equipment stock, you need to be providing the equipment when it's indicated by policies, procedures, and guidance at this point. I don't think that we're at the point where you can avoid those parameters as long as you have respiratory supplies. While we know that there's a shortage out there, we also anticipate that there are going to be some supplies coming at some point. I would not violate the current guidelines, if that's what the question is.
Okay.
I would also remind folks to go back to your emergency preparedness plan. If you're running out of supplies, I believe guidance or directions have been to make sure, connect with your public, local public health department to see if they have suggestions on alternatives. If you don't have specific resources, and follow their guidelines.
Additionally, we know that the shortage of protective supplies, came up early in all of our conversations, and we do know that that's going to be a challenge as we move forward. We continue to press the department and CMS about that, and the federal government, but also we are going to be looking at our own business partners and try to identify any that might have the ability to assist with this. We should have that done in the next day or so. So we are trying to work through some workarounds of the equipment issues, although to date, I'll be honest with you, we've not found a whole lot of new sources. But again, I would not, as long as you have equipment, I would think that it would help contain the spread, which is obviously the most important thing at this point as we move forward.
All right, the last question I have for now is, I think more of a shout out to our listservs and other resources. It says, perhaps crowdsourcing us, question mark.
I think that's a great idea. Maybe we should put that on our list of things that are really innovative that we could do. Okay, so I actually think we've hit most of the areas that I have here. One of the questions was, do you all feel like you're ready to accept some of these cases? Do you feel that you can comfortably adhere to the transmission-based precautions? I don't know if you want to speak to that today. Basically, I think that we've covered just about everything that I have. One of the things, a couple things I want to remind everyone, that we have established communication with the state person in charge for corona communications. So if you identify someone in your facility that has been confirmed, please let us know immediately. You do have to report that through the normal channels, but the governor's office has asked that we inform them directly through our association if anybody has a confirmed case. So please remember that. We've spent a lot of time here, so I don't want to continue a whole lot longer. What I'd like to do, first of all, again, I apologize for technical difficulties, but I would like you to send any best practices or any ideas of ways that we can further help. We're trying very hard to be supportive through this outbreak time. We would like to hear from you. Use our Safe and Calm at Leading HMI address, or you could always email me or Laura Funch. I think that we will put out a frequent Q&A based on this webinar. We will also be posting this webinar and the PowerPoint on our website and sending it out to attendees. So if there is nothing else today, I think that we're ready to close this webinar out. I'll give you like 2 minutes for any final thoughts or questions, not 2 full minutes, maybe a minute. And and if there are none, then we will say goodbye for today.
I have one last question here. Is the
okay, Dalton,
channel for reporting still through local health departments only?
You need to, without a doubt, report to your local health department. There's a state number that's embedded in the body of this webinar as well, and as you get it, you'll know it. I would report to both of those immediately. Those are the 2 that you have to report to. And then, of course, if you have a confirmed case, we ask that you also email our address.
All right.
Any other last questions?
I don't have any questions, but I do have one last comment, and it says, thanks for the morale booster. We appreciate you guys. So
well, thank you. We all know that you guys are on the front lines. We're trying our best to support you as we move forward. So you all have a great day as best as you can. And if there's anything you can think of that you haven't, we haven't talked about today, please let us know.
I do have one
last question. Take care. Oh, okay.
Just came in. Do we report to online situation EMR like we do for power outages?
Do you report to whom?
To online situation EMR like we do for power outage.
I'm not sure what that means. So if you're go ahead, Laura.
So if the question is like through Laura, through the state agency, when you have a power outage, yes, you communicate to them that you have a power outage and whatever fire watch, whatever the issue is going on. That's a little bit different than this. I mean, in terms of reporting to Laura directly for any survey or state or federal regulations sort of your certification, in terms of an allegation of abuse or neglect, that method is maintained. If you receive an allegation from a complainant or a family member or somebody that, perhaps you violated an infection control principle or something, you are required to report that through the normal mechanisms.
Yeah, so
right. I would agree. This is Deanna. My understanding is, although I'm not sure it's a bad thing to report to Laura, you only have to report to Laura if there is an abuse or neglect allegation associated with someone with such a diagnosis. Other than that, it is just the local health department and or the state number that's embedded in this webinar PowerPoint. Okay, having said that, again, I thank everybody for their patience. We will work on our technological difficulties. I think I'm going to have to call Spectrum. And we hope you have a good day. We will look for our member updates every day. They will be coming out at the end of the day with anything new. Take care. Goodbye.
Thank you, everyone. I'll be sending out a recording and the slides to everyone once we can get that recording downloaded here. So thank you, everyone.